All right, guys, welcome back to Underground Science. In this video, we'll be talking about C1 inhibitor deficiency, okay, or also C1 esterase inhibitor deficiency, okay, and this is also called, we should know the other name, right? It's also called hereditary angioedema, okay? There's also acquired angioedema, which we'll talk about a distinction in a certain finding, okay, at the end of this video. So hereditary angioedema. Okay, so let's go and get started. So let's talk about the pathophysiology first. So just like the name suggests, right? This is a C1 esterase inhibitor deficiency. That means we're going to be deficient in C1 esterase inhibitor. So in order to know what this will lead to, we need to know why C1 esterase inhibitor is even important, right? So it turns out C1 esterase inhibitor inhibits C1 of the complement pathway. Okay, so let's write that down. So C1 esterase inhibitor, right? Let's write the things it does here. So C1 esterase inhibitor, right? Inhibits C1, okay, hence the name, right? But what it also does, it inhibits a molecule called kallikrein, okay, or kallikrein. And it also inhibits factor 12. Okay, so let's go and see why this matters. We need to talk about a certain biochemical pathway first, okay? So remember, right? We have a molecule called prekallikrein, okay? And this is basically how bradykinin is produced. And remember, bradykinin increases, or bradykinin is important for doing what, right? Causing edema, vasodilation, and increasing pain. So let's see how bradykinin is produced. So you need a molecule called prekallikrein, and what happens is prekallikrein gets converted to kallikrein. Okay, and the way that happens is you need factor 12 for that to stimulate this reaction. Remember what we said, right? C1 esterase inhibitor inhibits C1, and what two other things did we say? We said kallikrein and factor 12. So we have that listed here. So C1 esterase inhibitor inhibits kallikrein and factor 12. Okay, so it's basically doing the opposite of factor 12. It's C1 esterase inhibitor is making sure that you keep inflammation in check, right? You don't want too much kallikrein because then you'll have too much bradykinin production. Okay, so anyway, let's say we have kallikrein now, right? Then kallikrein stimulates this reaction, right? It stimulates the reaction and converts, right, high weight molecular kininogen into bradykinin. And bradykinin increases your pain that you feel due to the inflammation, increases vasodilation, and increases vascular permeability. So these two things will basically lead to edema plus swelling, right? So that's what bradykinin does, okay? And that was the biochemical pathway in order to form bradykinin. So you can imagine right now, before we talk about the clinical findings, you can imagine if you're deficient in C1 esterase inhibitor, then you can no longer inhibit kallikrein and you can't inhibit factor 12. So if you can't inhibit factor 12, then a lot of kallikrein will be produced, right? Because you don't have C1 esterase inhibitor to keep this pathway in check anymore. So if you're producing a lot of kallikrein, that means you're going to produce a lot of bradykinin. If you produce a lot of bradykinin, you're going to get much more pain, much more vasodilation, and much more vascular permeability, leading to much more swelling, right? And much more edema. Okay. And then so that's basically what happens in this condition, right? C1 esterase inhibitor deficiency, or also hereditary angioedema. So let's go and see the clinical features and findings based on what we talked about. So we said in this disease, right, you have low C1 esterase inhibitor, hence the name C1 esterase deficiency, right? C1 esterase inhibitor deficiency. If you have low C1 esterase inhibitor, we said what does that lead to, right? If you don't have C1 esterase inhibitor, you can no longer inhibit kallikrein, and you can no longer inhibit um so you can no longer inhibit kallikrein and you can no longer inhibit factor 12. That leads to high amounts of bradykinin production, okay, which we said, right? would increase pain and increase swelling and edema due to increase in vasodilation, increase in vascular permeability, because that's what bradykinin does. Okay, and remember we said in the beginning that C1 esterase inhibitor not only inhibits kallikrein and factor 12, it also inhibits C1, which is the part of the complement system. So if you don't have C1 esterase inhibitor, you cannot inhibit C1, so you get high activation of the complement system, leading to even more inflammation. Okay, so that hopefully that should make sense also, right? So more activation of the complement system, more inflammation, a lot of bradykinin production leads to a lot of swelling and pain. Okay, so if you're getting all this edema and swelling and all that, right? So would you want to give antihistamines, right? Because usually if you have angioedema like that and swelling due to like an allergic reaction, for example, right? So you'd see hives too, for example, in an allergic reaction, not here, but in an allergic reaction, you would give antihistamine. So if you're seeing swelling and pain and edema here, would you want to give antihistamines, right? And like the answer would be no, because the swelling and increased inflammation and vasodilation and edema, all that is not due to histamine or an allergic reaction, it's due to bradykinin. So you would not want to give antihistamines because all of this is due to bradykinin, not histamine, right? Not histamine. So you would not want to give antihistamines in this case, right? That's why antihistamines or epi, won't really work in decreasing all of this symptoms that we talked about. Because it's not due to histamine or an allergic reaction, it's due to bradykinin, increased bradykinin production. Okay, so again, like we talked about, so if you're producing a lot of bradykinin, you're going to get a lot of vasodilation and a lot of vascular permeability. And what that's going to lead to is swelling, right? Angioedema. Now, where would you see this angioedema? You would see this in the face, right? Usually in the periorbital region, but you can also see this, right, in the lips, eyelids, even your genitals too, okay? So lips, eyelids, genitals, and your face. Okay, but the problem is that this, I mean, not the problem, but let's discuss if this is going to be pitting or non-pitting edema. So that's also important. So the edema is not due to increased hydrostatic pressure, right? That's squeezing fluid into your space, into your extracellular space, right? It's, or into your interstitial space. It's due to vasodilation and increased vascular permeability. So we should actually talk about the distinction more, right? So so remember, right? In non-pitting edema, let's talk about non-pitting edema first, right? Non-pitting edema, as we know, can occur like if you press down, right, on the skin, right? Then the edema won't pit. Okay, that's why it's called non-pitting edema. Okay. So if you have an area of skin that's edematous, right, and if you press on it, and if the indentation stays, then that's pitting edema, right? But if you press on it and there's no indentation, right, then that would be non-pitting edema. Okay. So that's the distinction there. Okay. But let's talk about more between the differences between non-pitting and pitting edema. So in non-pitting edema, this is mostly caused by mechanisms that would lead to vasodilation and increased vascular permeability. So remember, vasodilation and increased vascular permeability. Now, why does this happen? Because remember, vasodilation, right? So let's write this down. So vasodilation and increased vascular permeability. Okay, so why does this happen, right? Why does this lead to non-pitting edema? Well, remember vasodilation, right? Your vessels relax and widen. So this increases blood flow. And then increased vascular permeability, right? And what happens there is remember your endothelial cells can separate a little bit. Okay. And then this causes more space between your endothelial cells for things like, of course, water and fluids, but as well as proteins to leak out in your plasma, okay? So this will basically mean more plasma, right? More watery fluids that's present inside your plasma, right? Can leak out into the interstitial, into your tissue space, right? Your deep tissue space. But what also happens, right, is remember if you increase vasodilation and vascular permeability, right, you're so in the name, you're increasing permeability. So more things can flow from the blood vessels, right, into your deep tissue space. So what are those more things? So not only can fluids, right, come from your blood vessels into your deep tissue space, causing edema, but proteins can also. So proteins like albumin, for example, and proteins like certain clotting factors, right? And fibrinogen too, right? So fibrinogen and clotting factors, right? They're also present in your plasma, right? And things like that. So all of these, right, contribute to the non-pitting edema. Because what happens is, along with the fluids, right, if proteins like albumin and fibrinogen and clotting factors come in, right, what that will do is it actually makes the content that leaks inside that basically goes from your blood vessels to your deep tissue space, it makes that more protein, it makes that more dense and gel-like. Okay. So due to the proteins, right? The proteins that also leak out basically makes the content, right? The fluid content that leaks out from your blood vessels into your deep tissue space more dense and gel-like. Okay. Which basically, well, so then that means if you press on that edematous skin, right, which is rich in proteins now, that content that makes up the edema is rich in not only rich in watery fluids, but it's also rich in proteins. So if you press on that, and we said what did the increased protein content do? It made that edematous area more dense and gel-like. So it's basically trapped in the tissue matrix, right? So if you press on that edematous area, it won't indent, right? It won't pit because of the protein-rich edema, okay? Because of all the proteins, you make that edematous area more dense and gel-like. So if you press on it, it won't pit and it won't indent, okay? So that's why you would get non-pitting edema. But in pitting edema, right? In pitting edema, it's the opposite, right? If you press on that edematous area, it will indent. And so this what we see, right? We see pitting edema from different causes also. The main causes are either you have increased hydrostatic pressure, right? Increased hydrostatic pressure, or you have decreased oncotic pressure, right? And we'll talk about these in a moment. So decreased oncotic pressure, right? And even you can even see this in, for example, like liver failure or cirrhosis, right? So how do these things cause pitting edema? Okay, so let's talk about that. So so in pitting edema, right? If you have high hydrostatic pressure, right? If you have high hydrostatic pressure, what this does is it forces, so remember, in if you take your blood vessel right here, right? And the pressure at which the fluids go from your blood vessel into your interstitial space, right, is the hydrostatic pressure. So if you have really high blood pressure, for example, or if you have congestive heart failure, for example, we know what, right? We know that in congestive heart failure, what does your heart normally do, right? It pumps blood throughout your body. But if you have congestive heart failure, your heart doesn't pump blood properly out of the heart. So that means you're going to have more blood backing up. Okay. So if you have more blood backing up into your blood vessels, you're going to have higher hydrostatic pressure, which means more fluid due to the increased blood volume now, right? Because your heart can't circulate that blood properly. That increased blood volume will increase hydrostatic pressure and that'll lead to more fluid leakage. But turns out, due to this increased hydrostatic pressure, the fluid that forces out of your blood vessels is mostly watery and low protein. So it's high in water content and it's very low in protein content. What did we say non-pitting edema? We said non-pitting edema, you have water content, of course, but you have high proteins, high amounts of proteins, which makes that edema, the content of the edema, more dense and gel-like. right? Here you have low protein. Okay, so that's an important distinction. Now, another cause that we mentioned was decreased oncotic pressure. So, oncotic pressure is basically created by the proteins in your bloodstream, right? So, the more proteins you have, remember these proteins attract water. So, for example, one very important protein that we should discuss that helps maintain your oncotic pressure is albumin. Okay, so let's say this are albumin proteins. So what this does is it prevents excessive fluid from going into your interstitial space, right? Because if a lot of fluid goes into your interstitial space, you're decreasing your blood volume, which isn't good. So what albumin does is it helps retain the water part, right, of your plasma inside your bloodstream so your blood volume remains normal and you don't, excessively decrease your blood volume. But what's a condition where you may see low albumin in your blood, right? So of course, if your liver's failing, then you're not going to see much albumin in your blood, right? If you don't see much albumin in your blood, you can't retain water in your blood, which means the water will leak out to your interstitial space. And this water that leaks out, it turns out that of course this will cause edema, but the fluid that's leaking out is again high in water content and low in protein content. So it's more watery and it's not gel-like and it's not dense. What's another condition where you may see low albumin levels in your blood? Remember nephrotic syndrome, right? So, which is when we'll talk about that when we talk about the renal, when we do our renal playlist. But nephrotic syndrome, you have increased amount of albumin in your urine. So you have decreased albumin in your bloodstream. Remember, what does albumin do? It helps maintain your oncotic pressure. What does that mean? Albumin helps retain water inside your bloodstream so you're not shifting all that fluid into your interstitial space, decreasing your blood volume and decreasing your blood pressure. But if in nephrotic syndrome you have low albumin, you can't retain water inside your bloodstream, right? So the water will start leaking out into your interstitial space, causing edema. But again, because this edema due to low oncotic pressure, it's going to be high in water content and low in protein content. So if you have low protein content and high water content, right? If you press on that, it would make sense that it would easily shift, right, under pressure because it's not dense and gel-like because you don't have many proteins in the content that makes up the edema. So that's why, because you have such high water content and low protein content, if you press on this edematous area, right, with high water content, low protein content, then that edematous area will shift easily under the pressure, right? Under pressure. So under your pressure of your, it'll shift easily when you press it, right? Is what I should say. So if it shifts easily and it indents, that's pitting edema, okay? So that's a distinction basically between pitting edema and non-pitting. So let's go back here, right? In C1 esterase inhibitor deficiency, right? What happens? Due to increased bradykinin production, we see a lot of vasodilation, a lot of vascular permeability. What does that mean? More proteins can leak out, right? So hence the name permeability, inside vascular permeability. More proteins and water leak out, making the edematous content in your deep tissue space more dense, gel-like, and it trapped in the tissue matrix. So if you press on that, it won't indent easily and shift easily. So that's called non-pitting edema. So it won't pit, okay? Now, this edema and this fluid buildup can not only happen in your face, lips, eyelids, genitals, and so on, right? It can also happen in your GI tract. So if you have edema of your bowel wall, right? If you have edema of your bowel wall, of course we can expect that would cause a lot of abdominal pain and maybe vomiting and diarrhea also. And even more dangerous, if this edema occurs in your larynx, right? If you have laryngeal edema, edema around your larynx, that can obstruct your airway, right? Because we know your larynx, eventually you have your larynx, right? And that eventually goes to your trachea, right? Which is your windpipe, and that's where air goes and then goes to your lungs. So if you have laryngeal edema, right, then of course you may have a much harder time in getting air into your lungs. And that can cause airway obstruction, which is obviously really dangerous, right? And that can lead to stridor and dyspnea, okay, due to the airway obstruction. So you may have shortness of breath or you may have stridor. which is something you can see if you obstruct your airway. Okay. And remember, we already discussed this, right? You wouldn't want to give antihistamines because this isn't due to, all this edema isn't due to allergic reaction or histamine, is due to bradykinin increase, right? So you wouldn't see hives, right? Because it's not allergic reaction. You wouldn't see itching because it's not an allergic reaction and it's not histamine associated angioedema. Okay. So let's see what we have next. So an important diagnostic clue, it turns out, is the depletion of C4, okay, the C4 complement protein. Why would that be decreased? Remember, you have a you have a deficiency C1 esterase inhibitor. What does that normally do? C1 esterase inhibitor normally inhibits C1. If you can't inhibit C1 anymore because you're deficient in C1 esterase inhibitor, you have a lot of C1 activity and a lot of complement system activity. So remember, in the classical pathway, C1, right, the C1s specifically, does what? It cleaves C4 and C2, right? So if you're consuming a lot of C4 because you have a lot of C1 now, right? A lot of activation C1 because you don't have C1 esterase inhibitor, you're gonna consume a lot of C4, right? You're gonna break up C4 apart a lot into C4A and B and so on until you make your MAC, right? Your membrane attack complex, right? And so on, as we discussed in the complement system. So if you're activating your C1 a lot, you're gonna activate complement system a lot, and then you're gonna consume a lot of C4, and then because your complement system's enhanced, right? The complement system's occurring in an increased fashion due to the decrease or due to the deficiency in the C1 esterase inhibitor enzyme. Right. And so what remember C1, right, eventually activates C4 and degrades it, not degrades it, but it breaks it apart into what? C4A, C4B, right? And then we know C4B binds on the pathogen surface. C1 also activates C2, breaks that apart into C2A and C2B. And we know that C2A binds onto C4B too, so makes C4B2A, which is C3 convertase, and so on, right? So if you're consuming a lot of C4 due to a lot of complement system activation, it's expected to see low C4 levels, right? Of course, if you see the levels of C1 inhibitor, that's going to be low too, right? So your C1 inhibitor value is going to be low also. But one distinction to make that we mentioned that we would talk about in the beginning of the video was hereditary angioedema versus acquired C1 inhibitor deficiency, right? So it doesn't have to be genetic. You can also acquire this, right, due to older patients, for example, or malignancies, for example, right? And the distinction to make is you would see low C4 levels in both acquired and hereditary. You'd see low C1 inhibitor levels in both. But in hereditary angioedema, right, you would have normal levels of C1q. Okay. Remember, C1q activates C1r, which activates C1s, and C1s is the actual enzyme that breaks apart C4 and C2, right, and activates them also. So in hereditary angioedema, your C1q levels are normal, but in acquired C1 inhibitor deficiency, you would see low C1q levels, okay? And this will be an acquired C1 inhibitor deficiency. Okay, so that's just an important distinction to make. All right, and so that's basically it. I hope this video wasn't too confusing. I hope this video made a little bit of sense, helped a little bit. Thank you for watching. See you guys in my future videos.